Hello everyone. India has just celebrated administering 1 billion doses of COVID vaccine. Certainly a major milestone, but then out of the 900 odd million people eligible for the vaccine, almost half, about 45% have got the single dose and about 30% both the doses and 25% none at all. It's a major milestone, but then there is some distance to be covered as we can gather. But then there are those who are vaccinated still fear the asymptomatic carrier. There is still the fear of mixing and mingling. And then finally, when we also have started reopening schools, businesses are reopening, children are still left out. And so far, there is very little data in terms of the long-term safety from vaccines for children. And what is the way ahead, therefore, on this, and also on the issue of boosters. While there have been globally various countries adopting different approaches to boosters and the combinations that they are offering, we still seem to be lacking enough data and what is appropriate in the Indian context. Therefore, now, so to help us find answers to all of these, actually, we are fortunate to have with us one of the brightest minds in this space, Dr. Gagandeep Kang, a virologist of high repute and the professor at the Christian Medical College, Vellore, and also who is a member of the government's COVID COVID working group. So thank you so much, Doctor, for your time. It's really nice that you could be with us and help us through this.
Glad to be here with you.
Yeah. Thanks, Doctor. If I can begin with 1 billion doses after, how are we on the safety curve, as shall we say?
So I think it's a combination of the vaccination and infection situation that tells us how safe we are with regard to SARS-CoV-2. So it was very reassuring to have the data from the sero survey that showed that there was 67% seropositivity across India in June and July. And now, since June, we've had a lot of vaccine doses given out, which builds on top of that prior seropositivity, so that we should expect that in India, somewhere between 75 and 80% of adults are likely to have some level of protection. And that's really pretty good. But I think it's important from some of the remarks that you made earlier to point out that this is protection against severe disease and not protection against all infection.
Yeah, not protection against all infection, actually, against severe disease. Therefore, Doctor, now, in some sense, as one could imagine that since the firefighting phase is over, we needed some protection at least. Do you think the way the vaccines are being approached now, I mean, the vaccines so far have been able to tame the pandemic, but and in Indian context, mainly one vaccine really, I mean, which did the bulk of the work really. There is how does one now raise the, shall we say, the safety and long-term efficacy bar for the vaccines, so that, do we need to reset the vaccine development approach now?
So I think what we've done is use the tools that we had at hand to address the bulk of our population. After this, we are going to start to think about, can we do better? And one way of thinking about can we do better is to think about subpopulations that need vaccination for whom the current vaccines might not be optimal. So, for example, for children, or people who are immunocompromised, or people who have comorbidities. Do we need to rethink both the portfolio of vaccines and the need for vaccination in children, as well as the need for booster doses for some populations? So there is a lot that remains to be done, because there is still a significant proportion of our population that has not been either infected or vaccinated. And we know that for most mucosal infections, protection from vaccine or infection is likely not to be lifelong. So how long that protection is going to last, whether we are going to need booster doses, whether we need better vaccines, all of these remain questions. But for a country like ours, the best way to try and address how important these questions are is to have the data, right? How many cases of people who are infected go on to develop severe disease, how many require ICU care, ventilators, how many die. Then once you have that, then with different vaccines, how are the various vaccines performing to protect against these important outcomes? That will allow us to choose the best vaccine and also think about whether we should be thinking of new vaccines. If we look at data that's available in the West, the mRNA vaccines seem to give the highest antibody titers, but they've started to use boosters. Now, do we need to follow that? Do we need to think about other approaches given our high level of seropositivity? All of this requires very careful consideration of the data as well as the modeling of potential impact, and then rolling out a strategy against which you can test and validate the models. Lot for us to do.
Yes, that's true. It's quite a task ahead, actually. I was saying from the vaccine development itself, whether now that we have data, we have substantial time spent actually in terms of the way the vaccines work out. When we approach the newer vaccines which are coming in and the way vaccine development is being looked at, the safety parameters and efficacy, obviously there has to be some level of greater assurance, isn't it? I mean, whether one can theoretically talk of a zero COVID scenario or not, but is there any possibility of looking in terms of how this can be bettered, or is that just a utopian expectation?
All about so I did talk about vaccine portfolios needing potentially to be tailored for different populations and different scenarios. So which vaccine gives us the broadest protection? Which vaccine gives us the longest protection? Should we be mixing vaccines? Will that give us a better public health outcome than using 2 doses or 3 doses of the same vaccine? All of these are questions for which evidence is critically important, and we don't have that at the moment. In terms of safety and effectiveness of the vaccines, certainly for safety, we have a structure that is available in the country. But, the information, by the time it flows through that structure, then comes back to people, it can be quite a delay. For example, in today's newspaper, there is the report of the National AEFI Committee reporting that actor Vivek's death was not related to the vaccine. It was due to a myocardial infarction and that he had a complete vessel block. Now, between the time that the death occurred and the time that the analysis has come, months have passed. The vaccine program was very adversely affected. So when we think about safety, the reason that we want to monitor safety is to be able to reassure people that we have a handle on what's going on with the vaccine. This kind of delayed analysis is not reassuring months after the fact. What you need is a real-time responsiveness that says this is an unrelated event, right? The reassurance to be given by the right people. So our system for safety surveillance certainly needs to be strengthened. And in terms of looking at the real-world performance of vaccines, it's a bit disappointing that with 1 billion doses of vaccine given out, we are still relying for effectiveness data on studies that are done by one hospital or the armed forces or the police, especially because we have an electronic data capture system. And if we could link our testing and the electronic data capture system, then we would have a better idea of the performance of vaccines. The government does have a vaccine tracker that is trying to do this, but it gives you only protection for the vaccinated against death, not against severe disease, not against hospitalization. It doesn't tell you which vaccine is performing how. It doesn't tell you what the performance is in different states. So we know that in different states, death recording is very variable. So it's hard to make sense of the data that is currently available. I think stronger reporting systems, stronger data systems that talk to each other are critically important for all of public health, not just for this virus and this vaccine, but for all of public health. Understanding what really matters to people, what is affecting people in terms of their health, is the only way that we can think about developing an intervention or using a strategy and then measuring the effect of that strategy. So in addition to saying we gave 1 billion doses of vaccine, can we also say that that 1 billion doses of vaccine alleviated this many deaths, hospitalizations, etc.? Because that just tells you that all the effort that has been expended has had an impact.
So who gained how much because of the vaccine? We really don't know.
At the moment, we don't know. And for us, it's also important because of the high seropositivity rates. So if you have a lot of protection that is available because you were infected before, then the relative value of the protection that is contributed by vaccine is a bit less. So for us to understand that and to be able to contribute that to the global literature on vaccine effectiveness is very important, because this is not the last time we are going to see this virus. This is not the last time we are going to immunize for this virus. So if we want to build for the future, we need to use the data that we should have access to once we've given out this many doses of the vaccine. It's also important to remember that Covaxin is not being used in any other part of the world. We've given out more than 100 million doses of Covaxin. That is a very valuable source of data. And we should use it, because then that convinces the rest of the world that we have a safe and effective vaccine.
Doctor, this point about 1 billion vaccine doses administered, out of that, today we have 25% who have had no vaccine shot at all. And we have about 30% with 2 doses, but 45% with 1 dose so far. Now, this is a time when the second dose will start for at least those who have just got it from December onwards. And this, when in different parts of the world, boosters are being talked of here. And we are at this stage right now when we have still to cover the distance on vaccination. But then we are largely dependent on one adenovirus vaccine we have from serum. But what if tomorrow there is an antibody to the vector itself? What is I know we've had the Delta impacts quite severe earlier than anybody else on the planet, so to say. It's a severe hit. So where are we today in terms of, what is the concern that you think we should be having in mind before we get into complacency that we have administered 1 billion doses?
So I think if we think about who needs to be prioritized next, I wouldn't worry so much about the second dose coverage at this stage. We generally have low circulating virus in the country. What I would focus on is reaching that 25% unreached population first with 1 dose. And in parallel, try and get the second dose ramped up as well. But reaching that 75, the remaining 25% is very, very important. And I am not hearing enough of a commitment to trying to do that, in some states at least. Now, when it comes to thinking about the fact that we have mostly the adenovirus vectored vaccine, well, we know that the vaccine has worked very well in other parts of the world. Using this vaccine as a third dose booster, I think, needs to be informed by evidence. In the rest of the world, mostly we are using adenovirus prime doses and boosting with an mRNA vaccine, or if you've had an mRNA vaccine, boosting with an adenovirus vector vaccine. That combination works really well. And in Vellore, we are currently doing studies that is looking at people who've gotten 2 doses of Covishield and seeing whether we can boost their immune response with a third dose of Covishield or a dose of Covaxin. We hope to have those results available relatively soon, and that will be one part of the data that we need to be able to inform these decisions.